Hi all, welcome today. My name is Dr. Phil Xiu. I'm the series editor for the Crash Course book series, as well as the Global Medical Education Editor-in-Chief of ClinicalKey Student. And today we're going to be going through high-yield UKMLA topics. This is the first webinar in the series, and we're going to go through the cardiovascular system and cardiology as a clinical speciality. So, without further ado, let's crack on. Let me introduce you a little bit about myself. I'm the current editor-in-chief of Elsevier's ClinicalKey Student platform, which is in use throughout the UK, EU, and globally as well. And you may have heard of Elsevier. They publish books like Grey's Anatomy, Cromwell Clark as well, and they're aimed at medical students to improve the basis of medical knowledge. I'm the series editor of a series of 13 medical textbooks under the Crash Course book series brand, also published by Elsevier. This book series has been very well received by medical students internationally, having sold well over 1 million copies, as well as translated in 8 different languages. Today, we're going to be focused on the subject of cardiology, for which we have the Crash Course Cardiology textbooks, which is complementary to this webinar. This here listed is the UKMLA conditions of all of cardiology from the UKMLA blueprint. And we can see that these are the key common topics that you need to know as a trainee or as a student to be able to tackle the UKMLA AKT exams, whether that's for the PLAB exams or whether this is for the UKMLA AKT exams. The conditions listed on the left-hand side, these are the common conditions, what I term as priority 1. These you need to know to be aware of, you need to know to able to investigate and manage thoroughly, as well as the pathophysiology. Whereas the conditions listed on the right is what I've ranked as priority 2 or priority 3, and you should be able to make a diagnosis of and have an understanding and have heard of the particular conditions involved. And these are important because obviously with priority 1 conditions on the left on the list, then these are the ones that you need to make sure you're able to get all the questions on there right. And we're going to be focusing on those topics here today. Let's go through the first question here today. These are all high-yield questions, and this will really help with the knowledge of cardiology as a speciality. So we have a 77-year-old woman that's been treated for urosepsis with IV antibiotics. She has an irregular pulse. She has no chest pain or palpitations. She has a temperature of 37.7 degrees. Her heart rate is 119 beats per minute. Her BP is 138/98 millimeters of mercury. Her chest sounds clear. And we see a bedside ECG with a lead 2 tracing here. The question asked, the rubric, what's the most appropriate management for this patient? Is it option A, adenosine? Is it B, bisoprolol? Is it C, diltiazem? Is it D, digoxin? Or is it E, synchronized DC cardioversion? I'll give you a couple of seconds to have a think about what this could be. So we have a 77-year-old female that's been treated for ongoing urosepsis with intravenous antibiotics. She has an irregular pulse with a lead 2 tracing that we can see. We can see that she has got temperature 37.7, heart rate 119, blood pressure 138/98, and her chest sounds clear. Now, what do you think you want to do for this particular individual? Have a think, and we'll go through the correct answer now. The correct answer is bisoprolol. Okay, so obviously, let's go through the diagnosis. The diagnosis in this case is atrial fibrillation, and that's based on the patient's irregular pulse. And also we can see on the ECG on lead 2, there's an irregular QRS complex, which is the ventricular rhythm with a lack of clear P waves, in all honesty. And atrial fibrillation can often be triggered by acute illnesses such as infections, which is likely the case in this particular patient who's been concurrently treated for urosepsis. Now, in the management of atrial fibrillation, there are 2 main strategies here. There's rate control and rhythm control. Now, rate control focuses on slowing down the ventricular rate, without necessarily converting the AF back into sinus, whereas the rhythm control aims to restore and maintain sinus rhythm. Now, in this particular patient, this 77-year-old female that's been treated for urosepsis, the rate control is preferred for a number of reasons. Number one, the patient has no symptoms directly attributable to the AF. So she denies chest pain, she denies palpitations. So suggesting that the arrhythmia may have been present for an unknown duration, but we suspect urosepsis could be the trigger. Number two, the patient's advanced age and also the concurrent infection makes rate control a more appropriate and safer strategy compared to rhythm, which obviously can involve more aggressive interventions, potential complications, and may not work based on the concurrent illness. The first-line pharmacological agents for rate control in AF are beta blockers, such as bisoprolol. And beta blockers work by reducing the sympathetic drive to the heart, slowing down the AV node conduction, and decreasing the ventricular rate. And bisoprolol is a selective beta-1 receptor blocker, which makes it a suitable choice for this patient because it's got a less impact on the bronchial and peripheral vascular functions compared to the non-selective beta blockers. Now, what about the rest of the options? Why don't we give adenosine? Well, adenosine is a short-acting antiarrhythmic drug that's primarily used in the management of regular narrow complex SVTs, supraventricular tachycardias, such as AV-NRT, atrioventricular nodal reentrant tachycardia, and atrioventricular reentrant tachycardia, AVRT. It works by temporarily blocking the AV node. It interrupts the reentrant circuit responsible for the tachycardia. However, adenosine is not effective in the management of AF because it doesn't address the underlying mechanism of the arrhythmia itself, which is, to remind you, is the multiple random reentrant circuits within the atria. So adenosine isn't the right choice for this patient with AF. Now, what about option C, diltiazem? Diltiazem is a calcium channel blocker, and certainly that can be used for rate control and atrial fibrillation, and it works by also slowing down the AV node conduction, reducing the ventricular rate. However, there's a couple of reasons why it's not first line for this patient. Number one, beta blockers are first line in AF, and diltiazem and calcium channel blockers are generally second line. And two, diltiazem has negative inotropic effect, meaning that it can decrease the contractility of the heart muscle in itself. And obviously, in a patient with concurrent urosepsis, that's not what we want. What about option D, digoxin? Now, digoxin is a cardiac glycoside that can be used for rate control in atrial fibrillation, and it works by increasing the vagal tone and decreasing the AV node conduction, so it slows down the ventricular rate. Now, digoxin is not the most appropriate choice for a couple of reasons. Number one, it's not the first line agent, and number two, it's much less effective at controlling the ventricular rate during periods of, for example, high exercise or high sympathetic drive states. And now, obviously, this patient has got an acute infection, the urosepsis, which will probably be the cause, the driver of the increased sympathetic activity. So digoxin probably won't provide the adequate rate control that you want. What about E, synchronized DC cardioversion? That's also incorrect, because synchronized DC cardioversion is a method of rhythm control in atrial fibrillation, not rate, and involves delivering a timed electrical shock to the heart synchronized with the R wave of the QRX complex to convert the AF back into sinus. However, synchronized DC cardioversion is not the appropriate management because, number one, the patient has got no symptoms from it, and number two, we don't know the duration of the arrhythmia. And obviously, in asymptomatic patients with AF of unknown duration, rate control is preferred over rhythm. And the caveat to this as well, when you DC cardioversion, is you need to assess the patient's anticoagulation status to ensure that there's adequate anticoagulation to minimize the risk of any thromboembolic complications. Now, in this context, the patient's acute illness, the urosepsis, that can complicate the initiation of anticoagulation, so it favors a rate control approach. So, in summary, that is why option B, bisoprolol, is the best management for this patient with AF in the context of urosepsis, and that's the reason why it is the correct rationale. Throughout this presentation, I'm going to refer to the latest NICE guidelines to ensure that the information is accurate and up to date. Now, the diagnosis of AF is something that you might well be aware of, and that's based on both clinical findings and also ECG findings as well. On physical examination, you may detect an irregular pulse, which is a key indicator of AF. However, NICE also recommends anyone suspected of having AF should have a 12-lead ECG. That is the gold standard diagnostic tool. And obviously, when you interpret ECG, you've got to look for different features. Number 1, an irregular rhythm. Number 2, a narrow complex tachycardia with a QRS duration less than 120 milliseconds. And most importantly, the absence of P waves. Now, if you're not sure about the rhythm, use a piece of paper, help you identify the irregularity in the rhythm strip by putting it against the QRS complexes and seeing whether it's regular or irregular. AF itself can be classified 3 main types: paroxysmal, persistent, and permanent. Number 1, paroxysmal AF. That's characterized by episodes that terminate within 7 days, either that spontaneously or with any medical intervention. Number 2, some cases patients can present with normal ECG due to the intermittent nature of paroxysmal AF, and NICE suggests using a 24-hour ECG for patients with symptomatic episodes that occur less than 24 hours apart, and an event recorder for episodes more than 24 hours apart. And persistent AF fails to terminate within 7 days and often requires chemical or electrocardioversion to restore silent rhythm. Finally, permanent AF lasts more than 12 months or persists despite repeated cardioversion, and distinguishing between these types is important as management strategies may differ. Let's go through now some of the management of stable versus unstable angina. The initial management of AF really depends on the patient's hemodynamic stability. So, for example, unstable patients, characterized by hypotension, which is defined as systolic blood pressure of less than 90, chest pain, which could be suggestive of cardiac ischemia, or any signs of acute heart failure. So I'm talking about pulmonary edema, increased oxygen requirements. They may require urgent DC cardioversion. And this is really a life-saving intervention and should be performed regardless of the patient's anticoag status. Now, having said that, for stable patients, the focus shifts to rate control or rhythm control, as we discussed before in the last question. Now, in terms of rate control, the first-line agents include beta blockers, such like bisoprolol, or rate-limiting calcium channel blockers, such as diltiazem, depending on the patient's comorbidities. And it's important to note, as we discussed before, that CCBs should be avoided in patients with heart failure due to the negative inotropic effect. Now, digoxin can be recommended as a second-line option for sedentary or frail patients, so high clinical frailty scores, limited mobility, residing in care homes, or if they've got contraindications of first-line therapies, such as significant asthma, which preclude the use of the beta blockers. What about rhythm control? Now, rhythm control is normally considered for younger, more active patients with a clear onset of AF within the last 48 hours. So we're talking about chemical cardioversion that can be attempted, such as flecainide, the pill-in-the-pocket approach, sotalol, or amiodarone. But flecainide should be avoided in patients with ischemic or structural heart disease, and sotalol or amiodarone should be used instead. Now, people do also use electrical cardioversion using defibrillators, or they might do left atrial AF ablation, may be considered for patients with persistent symptomatic AF, despite the optimal medical therapy. Obviously, for all of these, then this needs a referral to the cardiac specialist. Let's crack on with question number 2. We've got a 43-year-old man that presents to the emergency department with a 1-week history of increasing shortness of breath and palpitations. He's got a history of rheumatic fever in adolescence. On examination, his heart rate is 134 beats per minute and is irregular. His chest is clear. There's no clinical manifestations of heart failure. ECG demonstrates AF with a fast ventricular response. An echo demonstrates a thickened and restricted mitral valve leaflet with a mitral valve area of 1.7 centimeters squared, and a normal bivent ejection fraction, and a left atrial volume of 50 ml per meter squared. What's the most appropriate management plan? Okay, I'll give you a couple of seconds to think things through. The various options are: A, emergency DC cardioversion; B, anticoag with direct oral anticoagulant and rate control. C, referral for urgent mitral valve replacement. D, anticoag with warfarin and rate control. Or E, referral with urgent mitral balloon valvuloplasty. So we've got a middle-aged man, goes to emergency department, increasing shortness of breath, palpitations, history of rheumatic fever in the adolescence period. Heart rate's very quick, irregularly irregular, no manifestation of heart failure. We see the ECG, which demonstrates AF with fast ventricular response, and we see also the echo response there as well. Have a think. What do you think is the best management plan for this gentleman? The correct answer for this question is D, anticoagulation with warfarin and rate control. This is because there is a high risk of thromboembolism with atrial fibrillation with rheumatic mitral stenosis. This is what the patient has, okay? The patient has rheumatic mitral stenosis. It's got previous history of rheumatic fever in the adolescence. That's what it's telling you, really. And also, the second thing is warfarin is the recommended anticoagulant in this particular setting, what is to do with the valvular issues. Rate control is important as well for symptom management because we know this patient has got clear symptoms of palpitations and shortness of breath as well. And also, it will prevent tachycardia-induced cardiomyopathy as well. So, a couple of different options here. Let's go through them. Number one, A. Why isn't it A? Why don't we do emergency DC cardioversion? Well, the patient is stable. The patient is stable, okay? And apart from the sensation of shortness of breath and also palpitations, there's no signs of heart failure. There's no sign of cardiac ischemia. So you do not need emergency rhythm control. What about B? How about anticoagulation with a DOAC and also rate control? Well, anticoagulation, I agree, is 100% indicated, but this should be used with vitamin K antagonists, so a warfarin, because there's no clear evidence to support the use of DOACs in this current setting. What about C, referral for urgent mitral valve replacement? Well, there's no current indication for direct mitral valve intervention just yet. There's normal bivent ejection fraction, so it looks all good. However, what there is indication for is anticoag and rate control. What about E, referral for urgent mitral balloon valvuloplasty? No, there's no urgent intervention. This patient has got moderate MS, moderate mitral stenosis. So the primary focus of initial management for this particular patient is anticoagulation with warfarin and also rate control as well. Now, obviously, how do you assess the need for anticoagulation in atrial fibrillation? Because we also need to do that to reduce the chances of thromboembolism, reduces the chance of subsequent sequential stroke. The CHATS-2 VAS score is used to evaluate the stroke risk, as you can see on the left-hand side. And a score of greater than or equal to 1 in males or greater than or equal to 2 in females indicates the need to consider anticoag. The Orbit score on the right-hand side assesses the bleeding risk, which is introduced in the NICE guidelines. Now, a score of 3 a score of 3 indicates medium risk, whereas a score of greater than 3 indicates high risk, and that warrants a careful consideration of the risk-benefit balance. The key thing in all of this that NICE emphasizes is shared decision-making, where you discuss this with the patients to ensure that they understand the benefits and the risk, and also the risk of significant bleeding as well. Now, what about anticoagulant choice? So the anticoagulant choice depends on a number of different patient factors, as we saw in the last question. So if there was a simple AF, then DOAC, such as apixaban, rivaroxaban, dabigatran, are first-line choice. Okay. However, whereas in patients due to valvular pathology, or those with metallic valves, or those with severe renal failure, so creatinine clearance less than 15 ml per minute, then warfarin remains the anticoagulation of choice, as DOACs are not licensed for these particular population. Now, you may ask, how do I remember which are the targets, which are the factors for the DOAC agents? Well, you can remember it simply as this, by their names. Apixaban and rivaroxaban target factor 10A, hence the X. Apixaban and rivaroxaban, whereas dabigatran targets factor 2A or thrombin, hence the T. Okay, just remember that. Apixaban, rivaroxaban, targets factor 10A, the X, whereas dabigatran targets factor 2A or thrombin, hence the T. Let's crack on with the next question. Hopefully you're finding this useful. A 60-year-old man presents with worsening exertional dyspnea over a period of several months. He's got heart failure with reduced ejection fraction and severe LVSD, which is left ventricular systolic dysfunction, and an estimated LVEF, left ventricular ejection fraction, of 32%. He got comorbidities include hypertension, diet control, type 2 diabetes, chronic renal impairment with an eGFR of 52. He's on current medications such as enalapril, bisoprolol, spironolactone, furosemide 80 once a day, and dapagliflozin around 10 mg once a day as well. On the clinical examination, he is clinically euvemilic. He's got heart rate of 62 and blood pressure of 132/74. We see an ECG which shows sinus rhythm with QRS of 117 and his BNP is 3,213. Now, what's the most appropriate next management step is the key question. Where do we go next? Have a think. What do you want to do? This is the patient that has got a BNP of 3,000. He's got ECG showing sinus rhythm, and he is euvolemic. He is on a lot of concurrent medications. He's got known LVSD, and he has got heart failure with reduced ejection fraction as well. Have a think. I'll give you 5 seconds, and then we'll show you the answer. Right, hopefully you've got some time to think through the answer. The correct answer is option A. Replace the enalapril, okay? In patients with heart failure with reduced ejection fraction who remains symptomatic despite taking an ACE inhibitor or an ARB, this drug should be substituted. So ARB or ACE inhibitor should be substituted for Entresto, okay, after a washout period. And all patients with symptomatic heart failure with reduced ejection fraction should be prescribed a beta blocker, obviously aldosterone antagonist, and an SGLT2 inhibitor. And these are the Flozin medications. Now, in these sort of outpatient settings, these sort of medications are commenced within a short interval between them for the best possible effect. Let me give you a bit more information about the salbutamol valsartan combined drug. This is an angiotensin receptor neprilysin inhibitor, ARNI. It combines the effect of neprilysin inhibition with angiotensin receptor blockade. And in the clinical trials, ARNIs has been shown to significantly reduce the risk of death and hospitalization for heart failure compared to ACE inhibitors alone in patients with heart failure with reduced ejection fraction. And because they don't just counteract the renin-angiotensin aldosterone system, but also augment the protective natropeptic peptide system itself. So this patient, despite being on the optimal doses of conventional HFrEF therapy, remains symptomatic, indicates worsening heart failure. So that's why we transitioned to the Entresto, because that can offer additional clinical benefit. Now, you've got to remember one of the key learning points here, there's going to be a 36-hour washout period when switching from an ACE inhibitor to Entresto to reduce the risk of angioedema. Now, what about the rest of the options here? What about option B, referral for cardiac resync therapy? So cardiac resynchronization therapy, known as CRT, is indicated for patients with HFrEF who's got wide QRX, so greater than 120 milliseconds, which is suggestive of desynchronous ventricular contraction. And CRT can improve the symptoms or the quality of life and survival in these cases. But in this particular patient, this QRS interval is unknown, okay? So indicate that this ventricular contraction is already likely to be synchronous and unlikely to benefit from CRT. What about option C? Increase the furosemide dose. Now, people give furosemide, they're diuretic, and they're essential for managing things like volume overload in patients with heart failure. But we've told you in this vignette, this patient is clinically euvemilic, so he does not show any signs of fluid overload. So by that, I mean things like peripheral edema, pulmonary congestion, and increasing the diuretic dosage, you can actually lead to hypovolemia and renal dysfunction because of his pre-existing chronic renal impairment. What about D? Reduce the bisoprolol. Now, bisoprolol is a beta blocker, so it gives a prognostic benefit in patients who've got heart failure with reduced ejection fraction because it reduces the effects of sympathetic overdrive on the heart, which can make heart failure worse. Now, while beta blockers can cause fatigue, they're critical in managing the HFrEF, and reducing the dose can lead to worsening heart failure. So they should only be reduced or discontinued if there is compelling reasons, such as hemodynamic issues, such as hypotension or bradycardia not responsive to other interventions. Now, what about digoxin? Now, digoxin has got a role in controlling the heart rate in atrial fibrillation, but it can also cause symptomatic relief in HFrEF, but it doesn't improve survival. Now, its use is considered when symptoms persist despite optimal therapy, and with the other agents that's been proven to reduce mortality. And in this patient, switching to an ARNI can be a more appropriate step to improve prognosis before the consideration of the addition of digoxin. As we can see in the previous question, the other patient had a BNP level of around 3,000. Now, let's go through what the significance of that is, in particular for someone with a diagnosis of heart failure. The diagnosis starts really with a thorough clinical assessment, is followed by a BNP or an NT-proBNP blood test, and then imaging, which is primarily echocardiogram. The symptoms of someone with heart failure include dyspnea, reduced exercise tolerance, orthopnea, and PND, paroxysmal nocturnal dyspnea. You may find examination findings. These are clinical signs such as bibasal crackles because of the pulmonary edema, the raised JVP, or pitting edema in the lower limbs. And obviously, you're going to get diagnostic tests. So we discussed about the BNP test, chest x-ray may show pulmonary edema, ECG, and echocardiogram. Now, there is a structured approach rather in terms of diagnosing heart failure, and the proBNP serves as a crucial biomarker, and that's released in response to ventricular stress. Levels below 400 usually indicate a non-heart failure etiology, whereas levels above 2,000 needs an urgent specialist referral. Now, when we talk about heart failure, it's really important to distinguish between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Heart failure with reduced ejection fraction, which our patient likely has, that's defined by an ejection fraction of less than 40%. So we want to aim to initiate treatment with beta blockers, ACE inhibitors as a first-line therapy to improve the prognosis. Now, for patients that are already on optimal doses of beta blockers and ACE inhibitors and still symptomatic, we want to add in a mineralocorticoid receptor antagonist, like spironolactone. And this approach can sort of alleviate symptoms and further enhance survival, but is really, really important to monitor for side effects, hyperkalemia, renal impairment. And despite optimized therapy, they may still become symptomatic, in which case we want to consider more advanced treatment like Entresto, the salbutamol-valsartan combination, which combines a neprilysin inhibitor with an ARB for synergistic effect, or consider ivabradine, which reduces heart rate without affecting contractility. Now, for these selected patients that are still no better, we may also want to consider things like CRT, resync therapy that can synchronize the cardiac contractions, that can improve efficiency, improve the symptoms. Now, obviously, these will be tailored and initiated by a heart failure specialist. Now, let's think about the heart failure with preserved ejection fraction, the HFpEF. Now, it's a clinical syndrome where the left ventricle has a normal or a near normal ejection fraction, so its pumping function is very much preserved. But the heart is stiff. It doesn't relax properly during diastole, so it gives inadequate ventricular filling, elevated filling pressures, and symptoms of heart failure, especially during exertion. So, how do we manage it? Number one, you manage the blood pressure control. It's important. You manage rate control, especially if you've got concurrent atrial fibrillation. And three, you might want to give symptomatic management, such as diuretics, relieve symptoms of congestion, shortness of breath, because of the peripheral edema. And you might want to do things such as manage their comorbidities, lifestyle modification, and then you keep on adjusting the therapy if needed. There's no specific HFpEF medication that's shown to reduce mortality, but ACE inhibitors and spironolactones are the mainstays of therapy for this condition currently. The New York Heart Association, or the NYHA classification system, that can help us communicate about the severity of heart failure. And that really guides treatment decisions. It can range from class 1, where the patients have no limitations in physical activity, to class 4, where the symptoms are present even at rest. And if you think about class 4, basically this patient is bedbound. So our goal really is to improve or maintain a patient's class as best as possible, knowing that the heart failure can progress over time despite our best efforts. So what about this particular case now? We've got a 54-year-old man that's got syncope. He's got heart failure with reduced ejection fraction because of ischemic cardiomyopathy, and his M1HA class is 2. He's already on Entresto, carvedilol, eplerenone, and also the Flozin medication, and they're considering device therapy. ECG shows sinus at 62 with left bundle branch, and the QRS is 150 milliseconds, consistent with the bundle branch. Now, what's the most appropriate step? Do you go for CRTP, cardiac resync therapy with a pacemaker? Do you go for a CRTD, cardiac resync therapy with a defibrillator? Do you go for an ICD? Do you go for a conventional dual chamber pacemaker? Or do you put in a loop recorder? So we have someone who's come in with syncope. He's got heart failure, he's got reduced ejection fraction, and he's got M1HA class 2. Is already on maximum therapy of Entresto as well as all the other medications. And the question is, where do we go from him? What sort of device do you want to insert for a patient like this? CRTP, CRTD, option C, ICD, option D, dual chamber pacemaker, or option E, implantable loop recorder. Give you 4 seconds to have a think. The correct answer is option B, a CRTD, a cardiac resynchronization therapy defibrillator. So a CRTD, let me go through this with you guys. CRTD device, it provides the dual benefit of resynchronization therapy and arrhythmia intervention. So this is the right choice for this patient. Now, why? This patient has got a history of ischemic cardiomyopathy. That's resulted in reduced left ventricular ejection fraction. That's reduced symptomatically in terms of a class 2 symptoms in M1HA. And also we know from the ECG he's got left bundle branch. We know he's got QRS greater than 120 milliseconds. These are all indications for CRTD because it will reduce mortality and prevent sudden cardiac death from these ventricular arrhythmias. And also this history of unheralded syncope, that suggests a potential arrhythmic event. So reinforcing the need for a defibrillator. Okay? What about CRTP? Now, CRTP is also known sometimes as a biventricular pacemaker. It's got 3 leads connected to the right atrium, the left and right ventricles. That's why it's got 3 leads. So it's called bivent pacemaker because it's both on the right and left ventricles. And we sometimes use biventricular pacemakers to treat people with arrhythmias caused by advanced heart failure. Now, obviously, patients with CRTP can improve cardiac performance in patients with heart failure and a wide QRS complex, especially those with a left bundle branch, because that tells me that there's desynchrony, there's not synchronous systolic function in the left and right ventricles. It doesn't address potentially life-threatening arrhythmias, and that could be the cause of that syncope that we saw. So a patient with HFrEF and a history of syncope, you must also think about the need for arrhythmia management in addition to the synchronization of ventricular contraction. Now, what about ICD, option C? So we know this patient has got this unheralded syncope, so you might think, right, there might be a need for prevention of sudden cardiac death, and there often is, especially in patients with reduced ejection fraction in the setting of ischemic cardiomyopathy. But this patient has got cardiac desynchrony, so we know that because of the left femoral branch, this one in QRS, and he's going to get more benefit because he's going to get more benefit from a device that will help correct the desynchrony of the left and right ventricles, so it's pumping in the correct time frame, be more efficient, and also defibrillation in case there's arrhythmias. What about dual chamber pacemaker? So dual chamber pacemaker is different from the biventricular pacemaker because a dual chamber pacemaker has only got 2 leads, and this connects to both chambers on the right side of the heart, the right atrium and the right ventricle. So, and this pacemaker helps the two chambers work together, contracting and relaxing in the right rhythm. And this contraction allows blood to flow properly from the right atrium into the right ventricle, and often is used for things like symptomatic bradycardia, where the heart rate is insufficient. Okay, but in the minute the heart rate is sufficient, it's just accept that the QRS and the left bundle branch indicate desynchrony, which I'm afraid the standard pacemaker doesn't address because it only affects the right side of the heart. So that's why it's not the right answer. And obviously, answer E, yes, the patient has had syncope, but an implantable loop recorder is more of a diagnostic tool. It captures arrhythmic events in patients with these sort of syncope. But the patient has got known cardiac pathology, and we know he's got ECG findings. We need to choose a device that can diagnose and treat, so such as CRTD, which is much more appropriate because you can actually interrogate the CRTD for any signs of arrhythmias doubt needed. Now let's go through question number 5. We've got a 55-year-old man that comes to his annual checkup with the GP. He's got persistent blood pressure, 187 over 112, and ECG shows abnormal voltage changes in the left ventricular lead, and also ST segment depression. Now, during fundoscopy, he's also found to have evidence of AV nipping, and urine dipstick was normal. So let's go through this. What are the options? A, weight loss and see again in 2 months. B, exercise stress test. C, admit to the hospital, give urgent intravenous antihypertensive medications. D, give oral antihypertensives and see in 2 months. Or E, begin antihypertensives and see in 3 days. So where do you go from here now? So 55-year-old man, persistently elevated blood pressure, not the first time round. ECG shows changes. Fundoscopy shows changes as well. Urine dipstick is normal. Give you 5 more seconds. Okay, guys, the correct answer is E. You want to begin oral antihypertensives and see in 3 days. Now, this patient has got hypertensive urgency, okay? And these have got signs of not acute end organ damage, more chronic end organ damage. So you need to start treatment with oral antihypertensives, okay? And we need to lower the blood pressure gradually. And when I say gradually, I mean over a period of days. You do not need to be too aggressive. Otherwise, you can get watershed infarcts or stroke mimic, okay? And you need to follow up within days as well, because you want to assess for treatment response. You need to adjust medication dosage, and you need to provide continued monitoring for any signs of worsening organ damage or adverse medication effects. So if there are other more severe symptoms, papilledema, renal impairments such as protein or hematuria, or cognitive changes such as hypertensive encephalopathy, they were present, then you will need to admit to hospital, intravenous therapy, intensive monitoring. But in the absence of those symptoms, you can go for a cautious approach with oral medication for a close outpatient follow-up. Okay? So why are we doing option A? Well, you need to do that anyway, right? You need to make sure they've got lifestyle modifications, and because that is part of the long-term hypertension management, because that will make improvements. However, in people with evidence of end organ damage, this is insufficient, and this blood pressure we know is persistent as well. So the urgency of the situation requires more pharmacological action on the same day. Okay, why don't you do an exercise stress test? Especially because of the ECG changes. I can see why you're thinking that, and obviously you might want to do that to investigate things like myocardial ischemia. Now, the ECG can cause concerns for coronary artery disease, but the main priority is to address the elevated blood pressure. Okay, that's the key. And doing an exercise stress test on a patient with elevated BP, it might produce a risk of provoking a hypertensive crisis or an acute coronary event, none of which we want. So why don't we choose C? I bet you a lot of students fall into the common trap of choosing option C. And that's incorrect, because if you admit to the hospital and the intravenous antihypertensive therapies are reserved for things like hypertensive emergencies, because there's only evidence of chronic changes. Whereas if you're thinking of acute, life-threatening end organ damage, by that I mean aortic dissection, acute pulmonary edema, hypertensive encephalopathy, etc. Whereas all the things that we see now are showing more chronic symptoms. So that necessitates reduction in period over days rather than the hours. And obviously, there's not going to be option D because we need to keep stringent follow-up to titrate the medication effectively and prevent progression to more severe complications. I think it's a great time to just go through hypertension management, because hypertension is just a very simple thing. It's very common to be tested in the exam. It's persistently high arterial blood pressure. It increases the risk of various conditions: heart failure, coronary artery disease, stroke, kidney disease as well. And primary hypertension can have no identifiable cause in about the vast majority of cases, more than 90%, whereas only in 10% is secondary due to things like renal, endocrine, or vascular disorders. Okay? So obviously, if there is age cutoffs as well, so bear that in mind. So the target clinic blood pressures are, if the age is under the age of 80, clinic blood pressure should be below 140 over 90. Whereas under the age of 80, ambulatory blood pressure, home blood pressure monitor, needs to be below 135 over 85. Take 5 off the top, 5 off the bottom. If they are 80 years and older, then the clinic blood pressure needs to be below 150 over 90, right? And the ABPM, HBPPM should be below 145 over 85. And this may need things like annual blood pressure monitoring, reviews, medication, and things like discussion of lifestyle on a recurrent basis. Now, we saw in the last case, this patient had a blood pressure over 180 systolic, really. And that really is a diagnosis of accelerated, or what we call malignant hypertension, okay? However, the difference is this patient has got hypertensive urgency in the last vignette. The reason why it's got hypertensive urgency is because the blood pressure is greater than 180 over 120 in the absence of progressive target organ dysfunction. Those were chronic issues. There is no progressive, there's no acute issues. Whereas malignant hypertension, accelerated hypertension, is the same definition, 180 over 120. However, there is also malignant changes, things like hemorrhage, retinal hemorrhage, papilledema as well. If this is the case, then you need to admit this patient to the same-day specialist assessments. Any people with these sort of signs need to go to specialist assessments, okay? Hepatic hypertensive encephalopathy, new onset confusion, chest pain, heart failure, acute AKI, acute kidney injuries. You need to send them to hospital with a blood pressure over 180 over 120. What about this patient? We've got this 63-year-old man, 63-year-old woman that attends a GP with controlled rheumatoid arthritis on methotrexate. She's got a history of type 2 diabetes. She presents with confirmed clinic blood pressure of 165 over 99, and this is confirmed on the second reading as well. Okay, so have a think. How are we going to manage this particular patient? Do we give amlodipine? Do we give bisoprolol? Do we give doxazosin? Do we give indapamide? Do we give ramipril? What do you do for this 63-year-old woman that's got concurrent comorbidities, that's got repeated persistent blood pressure over 160? Where do you go? What do you do? Going to give you 3 more seconds to have a think out loud for this particular individual. So this patient has got a stage 2 hypertension, okay? Stage 2 hypertension is characterized by blood pressure beyond 160 systolic or 100 millimeters diastolic, or a subsequent daily ambulatory blood pressure monitor of greater than 150 over 95. So in which case, you need to start medication on top of lifestyle changes, okay? If that's the case, option E is correct, because option E, ACE inhibitor, is the first line pharmacological treatment for patients with hypertension. And also the patient's got type 2 diabetes, so again, additional reason to give ACE inhibitors. ACE inhibitors will protect the kidneys from the effects of diabetes, which is a significant concern for diabetic patients who are at risk for nephropathy, okay? And this also got good benefits as well for the cardiovascular system. Very important in patients who are diabetic, who are at the higher risk for heart disease. So that's why you need to give ramipril. Now, what about the other options? Why don't we give something like amlodipine? Now, amlodipine is a calcium channel blocker, and it's used as a first line. I agree with you, in those who are over age of 55 without diabetes, but this patient has diabetes, or in those who are African Caribbean descent. Now, This patient's got diabetes, so that's why ACE inhibitors is the preferred initial treatment. Okay? Have a think. B is bisoprolol. So why is that incorrect? Well, bisoprolol is a fourth-line treatment for essential hypertension. Okay? So, and also, but if you think about it, if there is a patient with heart failure or post-myocardial infarction, then bisoprolol is indicated as well. So have a think about the comorbidities as well in terms of how that relates to it. What about C, doxazosin? Well, doxazosin is an alpha blocker, okay? It's managed BPH, benign prostatic hyperplasia, also manages hypertension, but is not first line, okay? It's normally used as an add-on for treatment-resistant cases as well. What about indapamide? So that's a thiazide-like diuretic that's used with the treatment of hypertension in combination with other antihypertensive agents. But indapamide is effective in lowering blood pressure, is not commonly used as monotherapy, whereas ACE inhibitors are preferred because they protect against diabetic kidney disease. Have a think, guys. Now, guys, this is the NICE guidelines, okay? So a single antihypertensive drug is often inadequate for the management of hypertension. So that's why an additional medication is often used until the control is gotten. And what we normally do is that we normally titrate to the highest tolerated dose at each step before we add in something new. But before we start a drug, before we start a patient, on anyone with a drug, we need to choose the right medication for the right person. So as an example, in step 1 treatment, we want to offer an ACE inhibitor or an ARB for people who are aged under 55 and who are not Black, African or Afro-Caribbean family origin. They may have type 2 diabetes. We want to offer them irrespective of age or family origin, okay? But if an ACE inhibitor is not tolerated, then we give an ARB, okay? Like a sartan. We never give an ACE inhibitor and an ARB at the same time to treat both. Now, in stage 1 as well, concurrently, if they are age 55 and older and they do not have diabetes, or they are of Black African Caribbean origin or Black African origin and don't have diabetes, any age, then we start them on calcium channel blockers. What happens if step 1 we don't control them? Well, if we're not controlled with step 1, either with ACE inhibitor or ARB, we normally add in something else. That means we normally add in either ACE inhibitor or ARB, and we add in a CCB, calcium channel blocker, or a thiazide, or conversely, on the other side, we've already tried calcium channel blocker, then we give in one or the other that we've not tried, either ACE inhibitor or ARB, or a thiazide-like diuretic. Now, stage 3 is where we combine everything. We give everything that's not been tried before. You might try ACE inhibitor and CCB, then we add in the thiazide on top. If you're already on CCB and ACE inhibitor, then you also add in a thiazide as well. So you basically throw in A, C, and D. ACE inhibitor, calcium channel blocker, and a thiazide, whatever you've not used before in step 2. What about step 4? So step 4, you've got to look at the potassium level of the patient. So if the patient with blood potassium level of 4.5 or less, you might want to give spironolactone. One of the side effects of spironolactone is increase in potassium levels, hyperkalemia. For those with potassium level of greater than 4.5, you might want to consider an alpha blocker, doxazosin, that we discussed, or a beta blocker, like bisoprolol, that's been previously mentioned as well. So what about this now? We've got a 64-year-old man that's found to have a blood pressure reading of 155/97 in clinic and 148/92 on home monitoring. He was asymptomatic, but he had well-controlled type 2 diabetes. He's on current medications of the ramipril, amlodipine, and indapamide 1.5. We see the blood test measurements: sodium 142, potassium 3.9, eGFR 72. How are you going to manage this patient? Do you increase the ramipril to 10 milligram BD? Do you review the blood pressure in 6 months and do nothing? Watchful waiting. Do you commence atenolol 50 milligram every day? Do you commence spironolactone 25 every day? Or do you refer to a cardiologist? What do you want to do for a 64-year-old man that has got a blood pressure of 148/92 on home blood pressure monitoring with a known history of type 2 diabetes, already on ramipril, already on amlodipine, already on indapamide with this blood test? What are you going to do? Going to give you 4 more seconds. The correct answer is option D, commence spironolactone. Now, spironolactone, potassium-sparing diuretic with anti-aldosterone properties. This is the preferred fourth-line agent for treating resistant hypertension. It's effectively effective when the patient's blood pressure remains above the target, despite the maximum therapy of ACE inhibitor, ramipril, despite the maximum therapy of calcium channel blocker, amlodipine, and also a thiazide-like diuretic, indapamide. And because spironolactone can lower the blood pressure, can also give additional cardiovascular protection. Now, potassium levels, very important. Remember we discussed this. NICE guidelines said potassium levels less than 4.5, consider spironolactone. Potassium levels more than 4.5, consider a beta blocker instead. Okay, so that's why we go for D. Now, this is also why option A is incorrect, because option A is increasing ramipril to basically 20 milligrams a day over split dosage. This is not the recommended strategy, because 10 milligram once a day is already at maximum therapy. Going more will have no additional benefit and may lead to renal problems. Reviewing the blood pressure in 6 months is inappropriate because the blood pressure is above the recommended levels already, so something must be done. What about adding a beta blocker, atenolol, 50 milligram? Well, it's fourth line, same as spironolactone, but obviously with with the beta blockers such as this, is the fact that actually the potassium level is good enough to support spironolactone. More importantly, we know this patient has got type 2 diabetes, and there are adverse effects with beta blockers on glycemic control and lipid metabolism. Okay, so these beta blockers can mask symptoms of hypoglycemia, and it can complicate things. So just be aware, be careful. And you don't need to refer to a cardiologist, okay, because you normally refer to a cardiologist when the patient is already on maximum tolerated dosages of multiple medications after stage 4, and you're not able to control it. And then you can refer, because referral at this stage is a little bit premature. So add in the spironolactone, and then if is not tolerated, then you may consider referring to the cardiologist. Guys, let's move on to question number 8 now. Question number 8. So we've got a 48-year-old man that's got central chest pain 6 hours after admission to a medical ward. He's got a 2-week history of feeling feverish, 2 weeks of feeling unwell. He's got a history of aortic valve replacement. Temperature was 38.8, so this is a fever. Anything over 38 degrees is defined as a fever. Heart rate 120, blood pressure 134/88. There's a systolic murmur, and ECG shows an anterior STEMI. What's the cause of the ACS? Interesting. What's the cause of the ACS? This is actually the pathology, and this is where the UKMLA questions are going now. They're not just asking what's the diagnosis. The diagnosis is given to you. They're asking about the underlying pathophysiology. So this is more of the applied type question, a bit more harder to tackle. What are the possible differentials? Could it be A, coronary dissection, B, coronary vasospasm, C, embolic phenomena, D, plaque rupture, or E, plaque shift? What do you think for this patient who is a 48-year-old gentleman with fevers and a murmur to the sternum with heart rate 120, blood pressure 134/88, and it's been ongoing for 2 weeks? What is your thought? Give you a couple of seconds now to compose it. If you've chosen embolic phenomenon, you are correct. Now, embolic phenomenon, they're very common in infective endocarditis, especially with what this patient has, okay? This patient has got a fever, he's got systemic symptoms, okay? He's got a murmur, and he's feeling unwell for such a prolonged period of time. All of this points to infective endocarditis. And an acute STEMI, ST elevation MI, strongly suggests such an embolic event from an infective endocarditis, because the emboli can dislodge and then can occlude the coronary arteries themselves, causing the MI. And this really is a medical emergency. It needs urgent evacuation and management. And it may need cardiovascular / cardiothoracic surgical referral. Now, I can see why if you chose option A, coronary dissection, I can see why you chose it, because it is a rare but recognized version of acute MI, because coronary dissection means that there's a tear in the coronary artery wall, and that can occur spontaneously or due to trauma, but is much, much less likely given the fact that this patient has got an infective history. What about vasospasm, right? So that refers to sudden constriction of a coronary artery, and that can cause MIs. And, while it is a potential cause for STEMI, it's an unlikely explanation for this patient's presentation. The fever, the tachycardia, the new murmur, point towards an infectious process rather than a primary coronary event. What about plaque rupture and plaque shift? These are probably the most common disruptors that are chosen by students when they answer this question. Now, plaque rupture is probably the most commonest cause of STEMI in general population because of atherosclerotic coronary artery disease. But in this patient with febrile illness, that's not the cause. And plaque shift is very similar to plaque rupture. So this is an atherothrombotic event that leads to a STEMI. It suggests a movement or a change in the plaque structure within the artery itself. However, within the context, again, of someone with a fever, new murmur, then it's going to be not the correct answer. So the answer is embolic phenomena. We have got a 50-year-old man that's got an anterior myocardial infarction that's treated with primary percutaneous coronary intervention 3 weeks ago. He's now complaining 3 weeks onwards from the event, breathlessness, swollen legs, without any chest pain. His observations show that his temperature is 37, heart rate is 92, blood pressure is 121/81, respiratory rate of 22, and oxygen level is 93 on room air. There are bibasal crepitations, heard on auscultation of the lung fields. He's got given some oxygen, and the blood samples are taken, and ECG is not given. So what's the most likely diagnosis? Is it atelectasis? A. B. Heart failure? Is it C. Left ventricular aneurysm? Is it D. Pulmonary embolism? Is it E. Secondary MI? What do you think is the most unlikely underlying diagnosis? This is a 50-year-old man 3 weeks after a heart attack. What's happened to him? And why? Now, let's take a look at the ECGs, okay? Let's take a look at the ECG for this particular patient as well. This is part of the question. I'll give you a couple of seconds to take a look through all the different leads to let me know what you think the answer is. So remember, this is the patient that has got a heart attack 3 weeks ago. This is the patient that's suddenly got chest pain and also shortness of breath. This is the patient that's got pulmonary signs of pulmonary edema, and this is the ECG that you get with it. Going to give you a couple more seconds to take a look through the ECG for you to be able to interpret it. And remember, options A, atelectasis, B, heart failure, C, left ventricular aneurysm, D, pulmonary embolism, or E, secondary MI, secondary myocardial infarction. So, what's the right answer? Well, option C is the correct answer, left ventricular aneurysm. So if you chose that, well done you. This man has got post-myocardial infarction, okay, 3 weeks on, and is in heart failure. We know it's in heart failure. He's got breathlessness, swollen legs, peripheral edema, okay, but no chest pain. He's got bibasal crepitations, oxygen level is concurrently low, consistent with acute heart failure, okay? And what do we see with the ECG? We see persistent ST elevation, okay? This is the classic presentation of the left ventricular aneurysm. Now, also be aware in V1 to V4, there are signs of old ischemic changes, dead myocardium, okay, because of the Q waves. This is pathological, whereas STEMIs, acute STEMI, without anything like that, will not have Q waves beforehand, okay? Whereas this one showed Q waves in the V1, V4, which is consistent with the heart attack he had 3 weeks ago. Okay, what about PE? Now, some of you may say, oh, could this be PE because of the low oxygen level, fast heart rate, etc., swollen legs, maybe a DVT? And obviously, you know, you've got to consider this might be important. However, for something like this, you might, even though get hypoxemia and dyspnea, the leg swelling should normally be unilateral, not bilateral, because the unilateral leg swelling causes deep vein thrombosis, okay? Rather than displaying bilateral edema that we see. And often, a pulmonary embolism is going to cause things like pleuristic chest pain, which this patient clearly does not have. And the persistent ST elevation after the post-myocardial infarction is not going to be explained by a pulmonary embolism. Now, what about secondary MI? So that's incorrect. Now, despite the ST elevation seen on the ECG, the patient is not experiencing any symptom of myocardial infarction. There's no chest pain, there's no sweatiness, no nausea, okay? Remember that. The patient denies any chest pain, okay? However, persistent ST elevation following an MI is very commonly caused by a left ventricular aneurysm. And the pathological Q waves in the V1 to V4 and the T wave flattening in V6 suggest that the ischemia is older. likely due to his previous MI. So this is a hard question, okay? But this is a question that if you get it right, that you will hopefully remember for the rest of your medical careers. What about this one? We've got a 54-year-old man that presents with sudden onset severe central chest pain and sweating. He's found to have an anterior STEMI, and he underwent PPCI, primary percutaneous coronary intervention. The echocardiogram shows left ventricular ejection fraction of 30%. So what are you going to do for this man, right? Are you going to give an ICD, implantable cardioverter defib, prior to discharge? Are you going to give CRT device that's put in because of the low ejection fraction? Or do you insert a pressure monitoring system to get more accurate readings? Do you repeat the echo? Or do you refer to cardiac surgery? So this is a man that's got sudden onset chest pain. He's found to have a STEMI. He's been treated by the STEMI. And afterwards, he has got a left ventricular ejection fraction. What are you going to do for him? The correct answer is option number D. You repeat the echo after at least 40 days of medical therapy, because NICE guideline states very clearly they want you to reassess the left ventricular ejection fraction at least 40 days after MI. We've had a significant reduction in LVEF. Now, we don't know what the previous baseline is, but presumably it's not going to be lower than 30%, because when you have dead muscles, that's going to drop your LVEF. Now, why wait 40 days? Because if you wait 40 days, it allows the effects of medical therapy and the recovery of the myocardium to be taken into account before you make decisions such as ICD placement, CRT devices, etc. Okay? Because this period of time, you might want to use beta blockers, ACE inhibitors, or ARBs, or aldosterone antagonists, which can actually improve cardiac function and then thus the outcome. So the 30% is temporary. Maybe you'll get way over 40% by the end of it, and thus some of the things that you might be thinking out loud are not needed at all. Now, what about A? In terms of ICD prior to discharge. Now, this patient has had a STEMI, and whilst ICDs are important for preventing things like sudden cardiac death, for patients with reduced LVEF, ischemic cardiomyopathy, something like that, or HOCM, this particular patient, this LVEF will improve with medical therapy. This is acute MI, this is an acute stress. So optimal medical therapy will result in cardiac remodeling. So why don't you give CRT? We discussed before with heart failure, right? It has to be persistent heart failure. This patient has heart failure because of an acute MI, acute stress. We don't yet know about the QRS duration, because a CRT device, cardiac resynchronization device, will benefit patients with ventricular desynchrony. The left and the right ventricles aren't synchronous anymore. So that causes broad QRS complex, i.e. bundle branch block, okay? And these are patients where, despite medical treatment, you still get these symptoms. Now, for someone like this, we don't know the ECG about the QRS duration, and also we have not given sufficient time post-MI to assess whether they're eligible for CRT. Option C is a red herring. You don't need to monitor it for chronic heart failure at all, and is not needed for post-STEMI, okay? Especially because this patient doesn't actually have any signs or symptoms of acute heart failure. Cardiac surgery, at this current context, there's no basis for onwards referral, just for a reduced LVEF post-myocardial infarction. Okay? But obviously, if you think about it, cardiac surgery may be needed if you're dealing with rescue therapy with a primary PCI, and actually if more than one vessel is involved, or maybe the primary PCI is not amenable for some of the particular coronary arteries, and you may need definitive revascularization down the line, but it's not indicated at this stage. So, in summary, for a patient with reduced LVEF post-STEMI, the most appropriate initial management is going to be starting guideline-based medical therapy treatment of at least 40 days. That's the main thing. Right, guys, let's crash through some of these main highlights here for management of patients post-myocardial infarction. It needs a coherent and comprehensive approach. Things include lifestyle approaches, medical management, you need to monitor for complications, and long-term follow-up. One of the key things, they're asking questions about cardiac rehabilitation, okay? And you might ask, what is cardiac rehabilitation? Number one, this rehab needs to be started before the patient is discharged from the hospital. And that involves things like physical activity, which is adapted to the patient's own ability. Lifestyle advice, so advice such as about driving, flying, sex, stress management, health education, so giving a holistic overall approach. Diet is so important post-MI. The advice is Mediterranean diet, so fruit, veg, fish, products based on plant oils. Not more than 14 units of alcohol a week, so low-risk drinking. And at a minimum of 20 to 30 minutes of exercise a day, and exercise is defined as the point of slight breathlessness. So increase the duration of intensity gradually. So if you can manage 20, 30 minutes, increase that to prevent deconditioning. Stop smoking, obviously, is very important, and obviously to reach a healthy body weight per the BMI. Now, what about medical management post-MI? So that might involve things like the dual antiplatelet therapy, potentially beta blockers, ACE inhibitors as well. ACE inhibitors can continue indefinitely, or an ARB if they're intolerant of ACE inhibitor due to a cough. And the aim is to titrate upwards every 24, 48 hours whilst inpatient with monitoring. And the aim is to completely titrate everything within 4 to 6 weeks of the hospital discharge. Now, what about beta blocker? The beta blockers, I'm talking about Deltizam or calcium channel blocker like Verapamil if beta blockers are contraindicated, or they've got something like acute heart failure. And you want to continue beta blockers indefinitely if they've got reduced left ventricular ejection fraction. Okay, that's the key thing. Now, what about dual antiplatelet therapy? Okay, dual antiplatelet therapy depends on the type of MI, whether it's STEMI or NSTEMI, and whether the patient actually had the primary PCI or not. And there are specific recommendations, which I'll go in the next slide later. Now, what about atorvastatin? Atorvastatin 80 milligrams recommended for the secondary prevention to reduce the risk of future ischemic events. That's very important. So even if the patient developed heart failure, beta blockers and ACE inhibitors should be initiated for their prognostic benefit, okay? Because it is about prevention or secondary prevention. However, if they have acute heart failure with pulmonary congestion, then beta blocker is contraindicated there and then, but may need to be started later on discharge when this patient is more stable. Obviously, you want to monitor post-MI, so such as echocardiogram, telemetry, etc. might be needed. And you want to monitor for potential complications. Left ventricular aneurysm, we discussed in the previous case. Thrombus, embolic events, or pericarditis, whether that's acute or Dressler syndrome. These are the main things to look out for. Let's go through some of the dual antiplatelet therapy in the next slide. So don't get worried about this, guys, but let's have a think about this first, okay? So you've got your STEMI patients, and this is specifically STEMI patient that's undergone primary PCI. So we're taking at the left picture here, okay? And the question you're going to be asking for these patients are they on an oral anticoagulant such as warfarin, Pixaban, rivaroxaban, okay? Because they constitute a large population of people who have ACS. And of those patients who have STEMI and they've had PCI and they are on oral anticoagulants, they should receive clopidogrel and aspirin. However, if they're not on oral anticoagulant, then they should get prasugrel and aspirin instead. Now, compare this. If we've got a patient who's got NSTEMI or an unstable angina, again, it's very much dependent whether they've got PCI or no PCI. Because NICE recommends if they've not had a PCI, then you need to use ticagrelor and aspirin unless the bleeding risk is high. And again, this is based on the evidence that ticagrelor is superior to clopidogrel, but ticagrelor does have an increased risk of bleeding compared to clopidogrel as well. Now, compare those patients, if they have an NSTEMI and they have PCI, that's a very similar question to what happened to STEMI, which is the fact that are they on oral anticoagulation? So if they are on an oral anticoagulation, then they go to clopidogrel and aspirin, so very similar to STEMI and PCI pathway. If they're not, then you want these patients on prasugrel, but obviously ticagrelor is a second-line option as well for those with NSTEMI or unstable angina that's had a PCI. This is a little bit tricky, guys, but this is the current latest NICE guidelines. So, guys, hopefully this high-yield crash course on the UKMLA topics is being very useful for you. This is the first one of the session on cardiovascular that we have. We covered through 3 major topics: ACS, arrhythmias, essential or secondary hypertension. And these are probably one of the main pillars that you're going to get within a cardiovascular question in either the question bank or actually in the real exam. You're going to be expected to get around 14%, maybe 15% of all your questions within a paper within medicine that relates to cardiovascular system. So it's vitally important that you get this correct and you don't miss this, okay? All right, guys, thank you very much for listening, and hopefully I'll catch you on another webinar on, again, a high yield topic. Bye now.